For decades, the story we've all been told about fighting cancer has been pretty simple and really powerful. Find it early, and you can beat it. It's the whole idea behind so many of our medical checkups. And this concept that early detection is our absolute best weapon, well, it just feels like common sense.
And that's the promise, right? This is what underpins all cancer screening. The idea is that by catching a tumor when it's still tiny, before it has a chance to spread, we can use treatments that are less harsh, get better results, and of course, save lives. It's the driving force behind mammograms, colonoscopies, you name it.
Well, here's the thing. As our technology gets more and more incredible, we can find smaller and smaller abnormalities now, we're bumping up against a much more complicated truth. It turns out that this amazing tool of early detection, it kind of has a shadow side. So, to really get a handle on screening, you can't just look at the good stuff. We have to see it as a balance, a trade-off between all those incredible benefits and a set of potential harms that are honestly not always obvious. Okay, so some of these you can probably guess, right? A false positive result, for example. That's where the test says you might have cancer and you go through all this stress and more tests only to find out it was a false alarm. But the toughest one to wrap your head around, and maybe the most important, is this concept called overdiagnosis. All right, stick with me here because this next idea is a little bit of a head scratcher. Overdiagnosis is not about finding something that isn't cancer. It's about finding something that is a true cancer, but a cancer that was never, ever going to hurt you. Let's break down how that's even possible. See, the key thing to get is that not all cancers are these aggressive monsters. Some are what we call indolent. They grow incredibly slowly. So slowly, in fact, that a person could live out their entire natural life and die of something else completely, like heart disease or just old age, long before that cancer would have ever caused a single symptom. So let's think about how this works without any screening at all. This is the classic path of a cancer. A person feels fine. A tumor starts to grow, and over time, what scientists call the sojourn time, it gets big enough to cause symptoms. That's the moment you finally go to the doctor and get a diagnosis. But, and this is the huge but, screening changes the game. A test spots a cancer way early on. But look at this diagram. The person dies from something totally unrelated, maybe a heart attack, before that cancer would have ever made them sick. That right there is an overdiagnosed cancer. We found something real, a true cancer, but treating it didn't actually make that person live any longer or better. Okay, let's hit pause for a second because this is super important and a lot of people mix this up. A false positive is when a test looks funky, but a biopsy proves there's nothing there. It was never cancer to begin with. Overdiagnosis, on the other hand, is finding a real malignancy, it is cancer, that just wasn't going to be dangerous in that person's lifetime. And this difference is absolutely critical because it leads us right to the problem of overtreatment. All right, so this whole overdiagnosis thing, it's not just some abstract idea from a textbook. It's happening right now in the real world. Let's take a look at how this whole benefit versus harm thing plays out with 3 of the most common cancer screenings. Let's kick things off with lung cancer. So you've got this huge landmark study called the National Lung Screening Trial, and the early data was, wow. It suggested that a whopping 18.5%, nearly 1 in 5 of cancers found by CT scans were actually overdiagnosed. And that just perfectly captures the problem. Our scans are fantastic at finding tiny spots on the lungs, but once we find one, we have a really hard time telling if it's a future killer or a harmless bystander. And when you don't know, the pressure is to treat it. Now, when it comes to breast cancer, the poster child for this whole debate is a condition called DCIS. It's what's known as a stage 0, non-invasive cancer. But here's the puzzle. Thanks to screening, DCIS now makes up as much as a third of all new breast cancer diagnoses. A third. And we now think that a lot of these cases would probably never turn into the dangerous invasive cancer we all fear. So we're stuck with this really difficult question. Who actually needs aggressive treatment, and who could be spared? And then there's colon cancer, where the complexity isn't just about what we find, but how we even go about looking for it. Just picking a screening test involves its own set of trade-offs. You've got the colonoscopy, which is super effective, but it's invasive, it needs sedation. Then there's a CT scan, which avoids sedation but exposes you to radiation. Or you have a simple stool test, which is easy but might not be as sensitive. Every single choice is its own little risk-benefit calculation. Okay, so after all that, after hearing about all these downsides and complexities, you might be thinking, should we just stop screening? And the answer is a big, resounding no.
The goal isn't to get rid of screening. The goal is to make it smarter, way more precise, and a whole lot more personal. See, the future is all about moving away from this one-size-fits-all model. We're talking about using your personal risk factors to decide when and how often you get screened. We're talking about using powerful tools like AI to help us predict which of those tiny spots are dangerous and which aren't. And all of this is aimed at one big goal: having better, more informed conversations between doctors and patients about what the real balance of benefits and harms looks like for you as an individual. And, the people who are right at the center of this, the radiologists who read these scans, they have a huge role to play. As the researchers who wrote our source materials say, they have to be key players in building the evidence that's going to help us get all the life-saving good from screening while doing as little of the harm as possible. So, in the end, it all boils down to this one massive question. This isn't about being for or against screening. It's about being smarter about it. And it's a question that everyone, researchers, doctors, and all of us as patients, is going to have to grapple with as we figure out how to best take care of our health in the years ahead.